A very warm welcome to everyone who is joining us from various places in Delhi and all around India. And this is an initiative by the Delhi Psychiatric Society to bring together people from and psychiatrists from all platforms, be it government sector or private sector, and provide a platform for psychiatrists to interact, and also helpful to the students that are members of the Delhi Psychiatric Society. So this would be an initiative by the DPS team comprising of the president, Dr. Vishal Chhabra. It was his brainchild, this Sunday servings. Then I would also like to congratulate Dr. Pankaj Kumar and Dr. Paramjeet Singh, who's also instrumental in bringing this together, this Sunday servings. I hope this initiative will go a long way and we'll be able to continue and contribute to psychiatry and psychiatry knowledge all around. And we are very happy to welcome actually stalwart speakers. I would now like to ask the President, Dr. Vishal, to welcome the speakers for today. Dr. Vishal, please, thank you.
Thank you, Dr. Manushri. So I'm very glad, I'm very happy that finally, after a lot of thought and hard work, we are able to start this. And I'm very happy, Dr. Mahesh, who's been a friend with me since my days in Manipal. I know him. He was in Mangalore, I was in Manipal, so we meet as PGs. So I know him so long, so more than 20 years now. So I'm very glad that we're starting this with him. And he's an apt man because he's running a big psychiatric center in Bangalore. And he does deal with health insurance. I'm very happy Dr. Shashi Rai ma'am is here. She's accepted to join us. She's from Lucknow. I'm sure Pankaj will give more official description of our speakers and chairpersons, but I'm very happy. And I'm also very happy that Dr. Gowda Gupta, who runs the biggest private center in Delhi, not centers, group of centers in Delhi, I should say. He has joined in as a chairperson. I'm very happy. And so I welcome also Nimesh sir with vast experience. I see Dr. Ashwini Kumar with vast experience in private sector also. So one from government sector, one from private. So Dr. Ashwini had one of the earliest psychiatric nursing homes in Delhi since I think 20 years. Sir is now in a semi-retirement mode and shifted to Gurgaon from Delhi. But he has vast experience, and so is Dr. Desai sir in government sector in various major hospitals. And we also have Dr. Anita Mahajan from Gangaram Hospital. Again, a lot of experience. I see Dr. Rajiv joining us now, Dr. Rajiv Mehta again from Gangaram. And I see a lot of people, I don't know them personally, but I think they are PGs or SRs from Delhi. And I welcome all of you. I welcome any seniors who have joined us. I think I saw one Dr. Ajay Kumar. I think he looked, I have not known him personally, but welcome to all of you. Over to Dr. Pankaj.
Thank you, Dr. Vishal. Thank you, Dr. Manu. And first of all, I welcome to all of you on this Sunday Servings first edition. This is like baby child of DPS and collective initiative of all of DPS with Dr. Vishal leading the idea. We were just sitting few days back and contemplating it for quite long. And it is finalized just within few days, and within few days it's out. I'm really happy to be part of this first edition. And now I also like to thank you all of speakers and chairpersons to be agreeing to be part of this first edition. So without doing much ado, I would like to just give a brief outlay. Although these speakers and chairperson doesn't require any introduction, they are stalwarts in themselves. I would like to welcome Dr. Shashi Rai. She is a senior psychiatrist and she was director of Sambal Drug De-Addiction Center in Lucknow. Ma'am is doing a great job in this area for quite time, and everyone knows her. She requires some introduction on this area. Second chairperson is a dear
Pankaj,
director of Tulsi Healthcare and Delhi and NCR. Sir started with a small center many years back. I know little history. Then sir increased his centers. Now he is, as Dr. Vishal said, heading one of the biggest private indoor center in psychiatry. So Dr. Gaurav Gupta is doing a great job and is always there. I was just a phone call away for all of us, including me. Thank you, sir, being here, part of it. And I would like to thank special thanks to Dr. Mahesh Gowda to be the first speaker of this first edition of today's our Sunday Servings. Dr. Mahesh Gowda is a director of Supanda Healthcare in Bangalore, and Dr. Mahesh has done a lot of work in this field. So I think that we couldn't find a better speaker who could do justice to this topic today. So, and I will thank you all of our senior psychiatrists, our colleagues, and our friends who are there on this Sunday morning with us. And without taking further time, I would like to request Dr. Mahesh to take over the session and start the session.
No, I think you first give it to our chairpersons, Dr. Shashi
Sorry,
and
sorry.
Dr. Gaurav for opening comments, and then
Yeah, please, ma'am. Chairperson first.
A very good morning to all seniors and friends here. It's a real privilege to be chairing this session of the first edition of Sunday Servings. And I thank DPS, especially Dr. Vishal Chabra, Dr. Banushri, and Dr. Pankaj for having given me this opportunity. I always feel like part of DPS, having spent 12 and a half years. So I mean, seeing you all, I just didn't feel that I have gone out of Delhi any time. So I'm really, it's like more of a homecoming for me. And coming to the topic, the fine print of mental health insurance. It's really the Mental Health Care Act. In few ways, we felt that it was anti the doctors, and there are a few things which are not in our favor. But regarding the patients, there have been few things which have been really good. And this coverage of patients with mental illness under the health insurance policy is a real boon. And if it, but many people are not still aware of the whole thing. So we have to spread awareness more and more. And well, there are few insurance companies who are complying. Though according to the IRDAI, everyone has to comply with the mental health coverage of mentally ill patients. So, and none other better speaker than Dr. Mahesh, who has done a lot of work on this. So with these few words, I request Dr. Gaurav to give his remarks, and then we move on. Thank you once again.
thank you, ma'am. Dr. Gaurav, you are on mute, sir. Dr. Gaurav, sir, you're on mute.
Thank you, everybody. Thanks for inviting me. Then I said, I don't know how much like. We are planning to start Tulsi as a first cashless facility for insurance. And I think very soon, maybe in a month's time, we might have the cashless hospitalization in Tulsi healthcare. Till now, we are able to get around 40 to 50 reimbursements for our patients from insurance. And I have two persons who are continuously working, and we is that how we can do it better and understanding. So maybe in future, I can maybe make a guidelines ready that how the insurance claim can be covered. There are a few intermediaries also come up. They are charging around 10 to 15% of the bill, and they are kind of making sure that you get the claim, or they upfrontly pay to the doctors. So which is going to be a very rewarding thing. And they are okay with this, that we charge 15% extra from the patient. And so the patient pay nothing in the hospital and everything get reimbursed. Definitely the process has to be defined, and things have to work out better. But I think it's happening. And I think in upcoming days, our patients will be able to get the insurance claim very easy. So let's listen to Dr. Mahesh. Most welcome, sir. And hopefully we will be more enlightened about this, the procedures. So I would just stop here. Thank you for inviting.
Thank you, Dr. Gaurav. Dr. Mahesh.
Good morning, everybody, and thank you, DPS, for this opportunity. And I didn't know it was the first edition. I hope this is an auspicious beginning for DPS Sunday servings. Vishal, I would request help for hosting the slides, please.
Yes, dear. Yeah.
Insurance has been a very important topic ever since treatment and mental health care has been there. But of late, because of the new act, it seems to have got increased velocity of the movement towards reimbursement. And I think with the government trying to make some provisions, with the court coming hard on the insurance providers to reimburse bills, I think there's a lot of hope for people who are actually trying for insurance reimbursement. So today I thought I will just look at a few important, next slide, Vishal.
Yeah. Is it moving?
It's not moving.
One second.
Yep, now it's moving. Thank you, Vishal. So I thought in the next half an hour, I'm going to talk on a few aspects of insurance as such in general, looking at the current status of insurance in the government sector and private sector. One slide back, Vishal. I was just talking on the highlight.
Yeah. I'm just trying to see. I think the slides having a mind of their own now. Yeah, got it. Yes.
Okay. Also, I'm going to look at what's happening in government sector, what's happening in private sector, looking at law and insurance and the support that we have, some amount of research that's happening on insurance reimbursement, the challenges what we have, what we learn from the West, and how important it is for documentation to get claims and the road forward. Next slide, Vishal. Yes, if you look at the current scenario, more than 70% of people, take treatment in private mental health care establishment. That means that if the insurance is not provided, 70% of the people are actually paying out of their pockets, which is a huge number. And if you look at an average outpatient consultation with the basic minimum essential drugs being prescribed, every person with mental illness or the family member is spending around 1,000 to 1,500 rupees per month as a maintenance dose therapy. It does not include hospitalization. It's only the maintenance dose therapy. Many a time, people are really stuck in this, cycle of getting into a relapse, getting dysfunctional, losing the jobs, also getting into a lot of psychopathology. Then they take treatment, get better, and it becomes a lifelong affair at times. And a family gets entwined in this sort of spiral of relapses. And it also will translate to financial crisis in the family, in most of the families. And a lot of disability leads to dysfunction leading to poor financial productivity, and the disastrous consequence that can result in social drift, suicide, sometimes hopelessness. So this is a very difficult thing, and that's why there's importance of getting the maximum number of people on treatment. Next slide, Vishal. Before the act of MHCA being in place, mental illness was kept as exclusion criteria, and the moment the insurance provider knew that we give the information of having a mental illness, it was strict exclusion. If they didn't know about it and subsequently we claim for insurance, it's going to be marked, code red sort of thing, and said that, it's a strict exclusion. They try and link up every other damn thing to mental illness and say that this is the reason for exclusion. Alcohol is one of the favorite thing for them, and somehow mental illness and alcohol has been the most shied thing for insurance providers. So according to MHCA, what happened was they have a section 21.4 in the chapter 5. So basically this empowers the person with mental illness to have right of equality and non-discrimination. So every insurer shall make provisions in the medical insurance to make sure the treatment of mental illness is the same or as in par with other physical illnesses. So by right, under section 21.4, every person with mental illness is entitled to take insurance, and it's a duty of the insurance provider to provide this sort of settlements for claims. Next slide. Okay, and what's happening is because MHCA had to align itself with UNCRPD and look at non-discrimination with this sort of insurance provisions, they're trying to make it fair and a reasonable way in which the person with mental illness is going to be treated and disability is also being taken care of. The new law will ensure that they receive monetary coverage and also professional help in terms of need, and also can alter the course of treatment and also the outcomes of therapies there, and the road of recovery can be definitely better if treatment can be made sure the delivery is happening and insurance is reimbursing this sort of claims. Next slide. Looking at the current status of mental illness and insurances, so there has been a thrust with the act, and so there has been guidelines, there has been gazette, and IRD has been issuing circulars. One of the circulars issued on 27 September 2019 talked about making some standardization on the exclusions in health insurance coverage. So earlier, if you look at what used to happen was no health insurance policy would actually provide insurance coverage for a lot of these sort of issues. For example, impairment of person's intellectual faculties by use of drugs stimulants or depressants, which is prescribed by medical practitioner, also was a strict, criteria for refusing claims. Puberty and menopause related issues, treatment of mental illness, stress and psychological factors and neurodegenerative disorders also was an issue. So all these things were kept as exclusion, and there are even now some strict exclusion in chapter 3, but these are very small number, but they actually made an attempt to standardize and make sure all these things are no more in the exclusion criteria. Next slide. If you look at what's happening in the insurance exclusion criteria, disorders of adult personality, disorder of speech, language, including stammering, dyslexia, all these things were under exclusion. So behavior and neurodevelopmental disorders also was a exclusion criteria. Failure to seek or follow medical advice or failure to follow a treatment that's been advised by the doctor was also a criteria. For example, if you look at a person with mental illness, you prescribe him medicines in X amount of doses for X amount of days. So what's going to happen is he may not take the same prescribed dose, or he may not take the dose for a particular duration that you prescribed. So not following a prescription was an exclusion. So failure to seek or follow an advice and failure to follow a treatment that has been offered was a strict exclusion criteria. That means technically 99% of the patients that we actually treat will be out of the exclusion criteria if this was actually there. And also pre-existing illnesses were also not covered. Expenses related to treatment of pre-existing illnesses and direct complication that would arise from these sort of illnesses was actually a strict exclusion criteria. And even if it happened after the date of inception also, they were looking at so many reasons to refuse. So insurance was actually paying the dirty politics here and finding reasons not to give claims. Next slide. Coming to the next one, they're looking at specific diseases and procedures in the waiting period. So now left with very few options. So what is the insurance company doing right now? They're actually trying to add a waiting period. For most insurance company, the waiting period for mental illness and reimbursement has been between 2 to 4 years. The least I found was with the Digit Insurance, Oriental Insurance, and National Insurance Policy. All these things are government insurances funded agencies, but still they have 4 years waiting period for mental illness. That means if you have a policy and if you develop a illness, up to 4 years, no reimbursement will be provided for this illness. And this 4 years is strictly followed, and anything that is there is straight away rejected. So I feel this 4 years is a very long waiting period. Imagine I tell myself I'm not supposed to get depressed or not supposed to fall ill, or by reasons of criteria of PWMI, I cannot claim any insurance for 4 years. This wait looks long. 1 year looks reasonable, or maximum 2 years, but the waiting period of 4 years is something very difficult. But the IRDA cannot regulate these sort of waiting periods, but they can only ensure that reimbursement is happening. For example, if there's an investigation or evaluation, there's also a code separate for that. Anything that is related to the primary illness under consideration, if it's happening during the admission period, then only it is being reimbursed. If it is something not related to the primary care for which he's been taking treatment, I think they'll use this criteria of exclusions here. Next slide. So I think court, including Supreme Court, also on various other cases have actually made observation to say that rehabilitation cannot be considered as an active treatment. So rest, care, cure, rehabilitation, and respite care have all been kept out of the purview of insurance and reimbursement. So anything that happens under the name of rehabilitation will not be reimbursed in the case laws that's been there, and the insurance also has kept this as exclusion. Anything that's there for just respite care, anything that's there for terminal people only to address physical, social, emotional, and spiritual needs of the person also will be a strict exclusion for them. And change in gender treatments is also a strict exclusion. Treatment of alcoholism, drug and substance abuse, and addictive disorders is also a strict exclusion as of now. Next slide. There are certain illnesses that are permanently excluded even now in the chapter 3 now. If I were to talk to neurologist colleagues, they are saying even now epilepsy is not being reimbursed. So I can understand childhood epilepsy, but even otherwise, we've been fighting so much for PWMI and reimbursement. Somehow my neurology colleagues have still not fought out, and epilepsy is still not reimbursed. Chronic liver diseases, pancreatic diseases, hepatitis B, HIV, and AIDS, this is not reimbursed. recently, with the circulars being issued for PWMI, they've also added HIV and AIDS reimbursement in 2019. So the HIV and AIDS reimbursement also has been claimed right now, and they've taken it out of the strict exclusion criteria, where section 3 is being used for permanent exclusions. Next slide. So what's happening with the thrust from the government and with the court coming heavily on the insurance service providers? So if you look at what's happening, few insurance companies have taken a lead and exhibited a positive approach for this change. Some of the insurance providers have started to launch specialized health insurance policies and products for only PWMI and making it more attractive for them to take it up. It is obvious that whenever they're making a provision and including additional illnesses, there's going to be an increase in premium, and we don't know what is the quantum of premium and costing that's going to really reflect when we cover PWMI at this point of time. However, they've been trying their best to try and manage with the same premium, but the insurance providers are not able to calculate what a typical acute exacerbation of psychosis would need in terms of financial inputs, in terms of depression, what is the input needed, how long should be treated, what is the therapeutic input needed, what would be the average consultation cost. A lot of variable parameters are there for which they don't have an answer. So at this point of time, the premium is just readjusted to some extent, but it's not the actual scientific calculation is what I've been told. However, there are a large number of health insurance companies who still do not comply with the IRDA, do not comply with the serious matters of the code that's been raised and clarified. They still continue not to reimburse and use this exclusion criteria and still refuse reimbursement. Next slide. Coming to some specific insurances, I was just looking at one of the data that was there in the net, and I could not read it up completely because it somehow protected it. I asked me for a paid access for this AXA France India policy. So there's a specialized policy from AXA France India, which has insurance partners in India to set up and launch a first ever mental health insurance cover for group policies also. They also have a helpline. I think it operates from Delhi, and they're actually providing free counseling and services also for people in distress. The people who have psychological related issues can call this helpline for some support, and they say these are all answered by qualified and certified counselors. It's the first ever standalone product in the space of PWMI, and it provides around 25,000 rupees coverage for virtual consultations, what has been told, with therapists, psychologists, and life coaches, which is very unique because most of them don't reimburse psychotherapeutic interventions. It also has up to 1 lakh rupees cover for hospitalization in a year's time. Next slide. This is one of the few circulars. I think if I were to recollect, there are around 4 circulars that's been issued till now, right from 2018, 19, 20, and the recent one came in 22. So all this thing is talking about this obligation of the insurance providers to follow a Mental Health Care Act and actually provide reimbursement. Next slide. So what is the government doing about it? If you look at the largest insurance policy in the entire world, it would be Ayushman Bharat, and it simply is huge because it agrees and it intends to cover the entire Indian population, which is a huge population. I don't think any other insurance company in any other country, whether it's government or private, has this sort of coverage. So it's covering up to 5 lakh rupees per family per year, and it covers the bottom 40% of the Indian population for secondary and tertiary care hospitalization, which is cashless, and it's covered in empaneled hospitals. If you look at what empaneling would mean, most of the medical colleges, government hospitals, and some private hospitals have been covered for all other treatment and related issues. But when it comes to management of PWMI, only the government centers have been empaneled. Private centers have not been empaneled, which still amounts to discrimination compared to the physical illness and reimbursement policies. So this becomes a contentious issue. I've requested IAPP to take it up and actually put a PIL and make sure it is in comparison, and even private treatment should be reimbursable. Although it was launched initially with around 17 packages, finally they thought about it, discussed with a lot of experts, and finally reduced it 10 packages in 2019, and 10 mental illness related problems and procedures have been covered. So for this, pre-authorization is mandatory, and for all healthcare consultations and treatment, procedures can be done only in public sector hospitals with specialty available. If it's not available, there's a scope for reference. All test reports, case sheets, clinical notes, discharge summaries, diagnosis related papers needs to be submitted while making the claims. Next slide. This insurance, if you look at what they're actually offering right now, 1,500 rupees for disorders, this 1,500 rupees per day, reimbursement in a general ward. For mental retardation, mental issues which are organic in nature, schizophrenia related issues, neurotic and stress related issues, mood disorders, behavioral syndromes associated with psychological disturbances, mental and behavioral disorders due to psychoactive substance. This is one of the only insurance that is actually available in India at this point of time, which actually covers substance abuse. So whereas all the other private sectors have kept substance abuse out of their reimbursement policies and said it's a strict exclusion even now. Next slide. Coming to costs on what is their offering for ECT, they're offering around 3,000 rupees for ECT, around 1,000 rupees for RTMS, and around 10,000 rupees for pre-ECT and RTMS investigation. If it's an investigation with imaging, it's 10,000 rupees. If it's an investigation without imaging, it's around 5,000 rupees, which looks fairly okay compared to what CGHS rates were offered. Next slide. So how, since health is a state subject, though central government is making a lot of this sort of provisions, the state has to finally adapt and make some provisions and changes to suit its requirement. So what's happening in Orissa is they have Biju Swasthya Kalyan Yojana, which actually provides similar coverage, but here they made a discretion and they said if it's a woman, up to 7 lakh rupees per year has been reimbursed, because they feel that pregnancy related outcomes, kids issues and postpartum related issues can be different, and they've actually made an additional coverage. So this looks very nice. For the first time I saw a differentiation in capping based on the sex here. And here the reimbursement is done by state government. It is not by any insurance company. It covers the cost of treatment of psychiatric disorders in government hospital only again. Arogya Karnataka is a similar thing at our state, and it covers residents of Karnataka, which includes mental illnesses also. It was initiated by government of Karnataka in 2018 itself, and it's for below poverty line people. And if they are above the poverty line, they have a co-payment method where they pay 30% of the cost involved and government pays 70% of it. It is still a very unique provision, simply because even though you don't have a strict insurance, you're not making a lot of payments to actually avail this sort of insurance. You may be above the poverty line, but still you're liable to actually take only 30% of the cost and 70% reimbursed by the government in government sectors only. Next slide. This is just the chart to show how much is being paid for various procedures here. It is general ward 1,500 rupees per day. If it is HDU admissions, 2,500 rupees per day, and ECT package 5,000 or 10,000 based on the imaging, and ECT is around 3,000 rupees a day, and all the investigation related stuff is also covered. For the general ward admission, it's for 2 weeks, and you can also take a subsequent renewal for another additional 2 weeks, so it becomes 4 weeks. For HDU admission, it's around 10 days. So the criteria for HDU is also defined, something like catatonia, severe depression, suicidality, violence, aggression. So they defined what a patient would entitle in case they want to be admitted to a HDU setup. Next slide. So looking at what's happening in private sector after 2019. So with no effort to some effort, there are some changes in insurance that's been happening, and they're trying to provide some sort of coverage. Public insurance companies like National Insurance Company and Orient Insurance Company have listed mental illness in their policy, and they also agree to indemnify the hospital or the insurer only in case of hospitalization. So OP coverage is not there. Counseling, cognitive behavioral services, psychotherapy is not covered. Alzheimer's disease, dementia of Alzheimer's type, Parkinson's disease are permanently excluded even now. Next slide. So as on October 21, the insurance plan for mental illness treatment is being provided by a few private companies. I was just looking at a few companies that I could easily get some data on. HDFC Ergo, Aditya Birla Insurance Company, Manipal Cigna Health Insurance Company, and Max Bupa Health insurance company. I also got to hear from the officials of Max Bupa Health Insurance last year. Apparently, I was told that they had reimbursed claims up to 1.2 crores in the year 2021. This is what has been told by one of the officials from Max Bupa Health Insurance. So from zero reimbursement from a single company like Max Bupa, they've gone up to 1.2 crores per year. So I think this is just the beginning and we have a lot more in store. Next slide. Coming to the impact of law and what actually prompted this sort of changes. So there's one case that happened in the Supreme Court of India. An advocate called Gowda Bansal had complained as a PIL, and it was held that there's differentiation and discrimination by the insurance companies, and a three-judge bench actually headed by Nariman actually wrote back to IRDA and the government, and they all agreed and they've done correspondences, and they've issued circulars to say that the Mental Health Care Act has to be implemented and insurance company have to reimburse, is what happened as a fallout of this PIL by Gaurav Kumar Bansal. Next slide. There's also one other case that happened in the High Court of Delhi. I think all of you could be familiar with this case. Shika Nischal versus National Insurance Company. Next, previous slide. Yeah. So basically, she had a health insurance policy from 2016. She purchased a new policy in May 2020. She got diagnosed with a mental illness in June 2020 and waited for 1 month. So because the insurance company said that they have a waiting period of 4 years, they refused to reimburse this claim. And even the ombudsman also refused to reimburse the claim. And so the court of doing. And the judgment was that reimburse the claim, and the practitioner was entitled, the petitioner was entitled for the complete amount of claim that was there. There's also a similar case by ABC versus IRDA in the High Court of Mumbai, and the fallout also was that the High Court actually came down heavily on the insurance provider and asked them to reimburse the claims. Next slide. So there has been a trust from the government to ensure that the policy of MHCA is being upheld, and this circular has been here. So what does the research talk about health insurance reimbursement and treatment gap and outcomes? So by any amount of common sense and logic, we understand that if insurance company starts providing reimbursement, there'll be more health seekers, and they will also get reimbursement. But somehow, in terms of the support that we have from literature, there seems to be non-conclusive. So we don't have anything direct that's published to go and tell the court or the policymakers that if you actually give us insurances, the people will avail treatment and that will lead to better treatment outcome. We don't have any such research that's been published to say there's a direct cause and effect relationship here. What is also surprising here, Vishal, I didn't feel Nishit, yeah. What is also surprising here is there are some insurance companies in the European countries specifically which also reimburse alcohol, nicotine, and benzodiazepine because they feel that these are licensed drugs, these are not illegal drugs, and if government has collected GST and it's a saleable commodity, they should reimburse these sort of claims because government is also liable for regulation here. So alcohol, nicotine is sold by government. Benzodiazepine are prescribed, and in case it becomes a habit and they get into addiction, and the logic here is the insurance company should provide and cover these sort of things. So there has to be a proactive effort and support, and there has to be a complaint again in form of a PIL to make these sort of amends in terms of insurance policy reimbursement. So there's also one other systematic review by Roberts and group which noted that having health insurance was frequently but not consistently correlating with health service utilization. So the assumption here is if there is more health service utilization, the treatment gap would reduce for common mental disorders, which will lead to better outcome and better quality of life, better productivity, and better overall functioning of the patient. Next slide. So what are the challenges in mental illnesses and insurances here? So basically, if you look at the illness itself, there's a lot of discrimination and stigma from the society, from the policymakers, from the insurance service providers. So a lot of things have actually limited the claims till now. Lack of knowledge about the illness and treatment and their rights about their claims also has been obvious. Previous slide, Vishal. And poor compliance with medications can be a huge challenge for us. Previous slide, Vishal. Previous. Yeah. So conditions like substance abuse, suicide attempts, and personality disorders even now are kept out of the purview of insurance reimbursement because they don't know what to do. They don't know because they believe that substance abuse, suicide attempt, personality disorder, there's some amount of volition, insight, and definitive control over all those things. If somebody has a control, if they decide to lose the control and get into trouble, why should the insurance company reimburse such claims? A lot of conditions in psychiatry are OPD based treatments like autism, SLD, ODD, ADHD, and conduct disorder. So only giving reimbursement for IP related admissions may really not help these sort of disorders. Previous slide, Vishal. Okay, rehabilitation, halfway home, psychotherapy, family therapy, all the psychotherapeutic inputs are actually outside the purview of reimbursement. And the long waiting period of 4 years is something that has to really shorten. And we have to work proactively to get this to 1 year or 2 years. But the discretion is lying still with the insurance service provider. Next slide. Another important challenge I'm seeing here is if a person who writes an advance directive and says, I don't want to take flupentixol, haloperidol, and I only want to take Invega Sustina, should the insurance company reimburse this sort of choices made by the patient? Whereas the practitioner believes that, taking any other Indian generic version of the drug will be useful. If a patient decides to choose a costly option, should the insurance company reimburse that sort of choices made by patient by way of advance directive? There's also another important issue here is right to confidentiality, section 23 of the MHCA. Here, what's happening is the patients sign blanket cover for them to seek all the health-related information from us. The release of information is unlimited, and once the patient signs up, the companies will have an access to all the treatment-related records. I strongly believe that the insurance company need to know about certain basic minimum information only, but still insurance company insists on complete records. So right to confidentiality is something that will come in way of releasing this sort of information. So it will be a good practice if we take the request from the patient, release the complete set of documents to patient, and patient submits it to insurance company, and we giving it to the insurance company directly can be a major issue here. Next slide. So we have done a lot of things aping the West, and we copied a law that's been existing in the UK and copied a few other parameters that's there in other Western countries. So what do we learn from the insurance and reimbursement policies that they have? One of the best insurance policies that they have is in United Healthcare Insurance, which has a lot of positives here is what I felt. It has got an impressive network, 24/7 support for mental health issues, treatment options for substance abuse disorder is also there, teleconsultation is reimbursed, online resources are there for them, psychotherapy, counseling, group therapy, CBT, all those things are inclusive. So if United Healthcare Insurance can provide, why not an insurance company in India? Of course, there'll be an issue of premium being readjusted. They can add a pre-existing illness loading and alter the finances here. But why can't an insurance company in India provide on similar lines? Next slide. We have Medicaid in USA, which also go ahead, other than what is there in the other policy here, they also reimburse assertive community treatment related costs also. So the cost for a nursing staff or a healthcare worker to go visit home, administer medicines, injectables is also reimbursed by them. And this is a very proactive thing to ensure that the treatment happens in community and can greatly alter the treatment related outcomes of the patient and the illness. Children's health insurance program in the US and the TRICARE for the war veterans, all these things have similar things, and they're excellent policies which have actually worked in the favor of PWMI. Next slide. So NHS, all of us know, I hear from my colleagues, I hear from a lot of patients who get reimbursement and treatment in the United Kingdom. They have unlimited access to all the possible intervention that happens in psychiatry. Of course, there's waiting period for getting specialist attention. These sort of issues are there because of manpower crunch. But by far, they are able to cater for most of the requirements of a PWMI in terms of IP, OP, therapeutic services, medical services. Reimbursement is not there simply because it's all free under the NHS, and they have covered everything possible under the spectrum of PWMI. So I think if United Kingdom can do it, we can also do it, is what I strongly think here. Next slide. So there are certain fine prints that we must be aware of, simply because the insurance providers are hard pressed now to follow IRDS requirement. So they will be having some difficulties in terms of finances. So they try and manipulate whatever is there in the scope. So capping for mental illness has become one of the fancy thing. There's some insurance company which cap the reimbursement claim to 10% of the total sum insured. For example, if it's insured for 5 lakh rupees per year, they say only 10% of it can be utilized for mental health related services. Rest of it can be used for other services, but the capping is 10%. There are companies which cap it at 20% also. They also, insurance companies, keeping exclusions for DSH, suicide attempt, and substance abuse disorder. So we have to be watchful on that. OPD consultation, OPD-based medications also not covered. Daycare procedures like ECT, RTMS also not reimbursed. Psychotherapy and all the other therapeutic interventions not covered. Any assessments done on OPD basis is also not included. So a lot of work that we do with PWMI would be on OPD basis. And so practically getting reimbursement only for IP care also is still not the solution to what we are actually looking at. Next slide. So hospitalize a patient for diagnostic of monitoring purpose. If you think that you are not clear of diagnosis, so you want to admit and just monitor and review your diagnosis, that's still not covered. Waiting period of 2 to 4 years for pre-existing disorders is something of a great concern for us. There are separate waiting periods for different illnesses also in some policy. For example, he may say for schizophrenia it's 4 years, for depression it's 2 years. So they can have these sort of variable parameters for giving reimbursement. Any upgrade in the policy also, they will say that it's not covered till the waiting period is over. So you're upgrading it from 5 lakh rupees to 10 lakh rupees a year. They're trying to enforce that, once you upgrade, the new waiting period will start in. So the court will not look at this in a spirit of legislation. They may feel it is arbitrary, and they have to give a rationale for these sort of things. And the court may still agree to let the reimbursement happen. There can also be a capping on the room rent. For example, if it's below 5 lakhs, they may say you can only avail a general ward bed. And capping on the number of inpatient days also can be done. They're also trying to look at what is the package that they can offer till they really come up with a sort of package. These are variable parameters. Next slide. So what do we do when we are buying a policy? So it's our duty, and we must educate our clients and families that we must disclose all pre-existing illness, because at some point or the other, there's going to be issues where they will get access to a data that I mentioned somewhere, that he was smoking or drinking or actually having depression in the past and things like that. So everything get linked, and over a period of time, I think if there's digitalization of records, and we have a policy to maintain records online. So we have to maintain minimum data on the e-Manas is our requirement in the state, and it may get enforced in other parts of the country also. So if you start maintaining this sort of digital prints of the patient's related illness related information there, they all can get linked. So we tell and encourage them to only give everything positive and make them disclose everything and not hide anything, because by hiding they will not be able to achieve anything here. So do not hide any health related information is what I'm trying to tell my clients also. Read the document thoroughly and completely before buying the policy. Do not depend on an agent's review of the policy. If there's any need for hospitalization, try to prefer something that has a comprehensive cover for inpatient care. If there's a need for only OPD services, try and look for policies which have OPD coverage. So they must be encouraged to look at this sort of fine prints there. Next slide. So for successful claims, one needs to have a completely filled out form, which is in accordance to the inclusion criteria, and there must be no exclusion criteria. Psychiatrist advice for admission under section 86 versus 89, and related certifications have to be there. Prescription, discharge summary, final hospital bill, original investigation reports, medicine bills with prescriptions, final payment receipts, a cancelled check of the insured bank for reimbursement also is needed. So all these things will become the basic documentation that we need to submit for successful claims. There should be no discord with what we are writing. Everything should be in a flow that actually suits the inclusion criteria for them. Next slide. I'm also looking at what can happen in ideal scenario if all the insurance company starts reimbursing, and will it really make a change in the patients, or will there be a policy abuse is what I was thinking at. In an ideal scenario, if all insurance claims for mental illness were claimed, we would see also a misuse of this sort of facility by a lot of people. I'm looking at a scenario if somebody is under pressure by the work that he has in working in MNC. He has got long working hours. He needs sick leave. He does not get sick leave. They have got strict timelines and a lot of works are there that he has to complete. So he may just come and tell us that he's depressed and he's suicidal. And the moment I get the word suicidal, I will say that he's met the threshold for admission. So if I were to admit him and he takes a 2 weeks break, he gets leave, he gets a paid leave, he get a medical reimbursement for the whole thing. Whereas in fact, he may not be actually suicidal. So should insurance also play a role here and reimburse all these sort of claims is what I was thinking. Another scenario I was thinking is if somebody keeps drinking, and he exhausts all his resources, he is left with no money. If he stays at home, he gets into withdrawal. So he agrees to get himself hospitalized because he has no money. So 2 weeks treatment happens, and if alcohol is related treatment related issues also are reimbursed, he'll get free treatment, get medication support. He gets to go back home, and if he's accumulated some money, he can again start drinking. He'll only use the hospitalization and related reimbursement for detox, and he has no learning that will be happening. I'm just looking at scenarios. So could there be a potential of abuse of insurance reimbursement for people with alcohol dependence, and some people who may claim suicidality is what I was thinking. Next slide. The road forward, I'm thinking that the insurance may come up with a lot of packages. They may say if it's acute exacerbation of schizophrenia, 2 weeks treatment, so much is the money, so much will be a consultation fee, so much could be a therapeutic intervention. So they may all come up with packages to determine what could be reimbursed. The other thought is, should there be coverage for maintenance treatment after stabilization is over? So I do a lot of work and get him going, and they reimburse the inpatient care and acute management problem. Whereas if he does not continue the treatment outside, the treatment is still, outcome is still not there yet, and he's definitely going to relapse if it's not continued. So medical reimbursement should also include the cost of stabilization phase and maintenance phase is what I've been thinking. Will the insurance cover psychotherapy, counseling, and how long is it needed? What's an average duration session? If he's an RCI qualified therapist, what is the average cost he must be reimbursed? All these things are questions that still they don't have an answer, and we also don't have a clarity. Will stay in a halfway home be considered for reimbursement? Long stay option is definitely a question that I keep asking myself. Should all suicide attempters get insurance cover even though they do it deliberately? Sometimes it is only a DSH attempt with no intent to kill themselves. So it could be parasuicidal behaviors. But by law and legislation, government has responsibility to rehabilitate people who attempt suicide also. So in terms of the spirit of legislation and the policy making, there should be a scope for reimbursement of suicidal attempt, irrespective of whether it was parasuicidal or actual intent of suicide is there. We never know when we miss the actual patient who's really suicidal. Should the illness go untreated, the damage that can happen in terms of general physical health, poor oral intake, poor personal hygiene, leading to a lot of disability dysfunction, should the insurance company pay and compensate this sort of disability that can arise? So you're saying that I will not pay for the illness, but if there's a disability that comes in by not treating, who becomes liable here? Is the patient liable because of his illness, or the insurance company which refused to pay this sort of reimbursement, finally leading to other medical issues and other dysfunction? Should they be actually getting into this arena of reimbursement for compensation? Next slide. So in conclusion, I was looking at having health insurance is a necessity, and covering all family is definitely a necessary act. It's a financial risk that we are taking if we are not actually taking insurance. There has to be some form of insurance for all of us. Choosing suitable mental health insurance depends on your requirements and the finances that we are actually, the financial position that we're actually in. Providers offer a range of services to support people's mental well-being, so it's essential to carefully review each policy, ensure that it covers whatever our specific needs are. Thank you so much for patient listening. Over to the organizer.
Thank you, Dr. Mahesh, for such a lovely, lucid presentation. and enlightening all of us with this information, which is very vital in coming days. And this is a very good presentation, I would say, and thank you, you on behalf of DPS. And I think there's a few questions in the chat box. I would like to put up those questions. I think we have answered few of them. But first question is, is psychiatric OPD consultation a part of reimbursement? I think you have answered it, but if so, then how can OPD clinic become empaneled with insurance providers so that it can become cashless like other hospitals? Dr. Mahesh?
Yeah, if you look at the current policy that I reviewed, only AXA France India was the only thing that had around 25,000 rupees coverage for virtual consultation inclusive for OPD management. That's the only thing that I could read about. I've reviewed all other insurance like HDFC, Oriental Insurance, National Insurance Company. All these things are kept OPD consultations exclusions. So still, it's evolving. I think over the next 2 to 3 years, a lot of changes is going to happen. Whether they want it or not, there's going to be a thrust on the patients, NGOs, and the court. The policies are definitely going to evolve, and I think OPD consultations also will be a reality. Right now, this is the only policy that I could find.
And there is one more question from Dr. Nanbita Sen Gupta. She asked, similar to Odisha and Karnataka, is there any other government insurance policy in Delhi?
I'm not sure. I think Dr. Nimesh Desai would be able to tell us on this, because each state has its own policies. PMJAY is the central policy, but they have state adaptations of this and they reimburse. It'll definitely be a requirement. I think if you look at the current government in Delhi, I think they've set up a lot of clinics offering free treatment in the Mohalla clinics is what I read about it. But for private insurance providing agencies, I think it's going to be same across the country. Government insurance policy, there's going to be definitely some sort of hybrid model that's going to happen. Dr. Nimesh Desai, any ideas, sir, on this?
So the thing is, the national health policy in the public sector has not been adopted by the Delhi state government. I mean, we will all know why, like some other states. So the thing is that the state government has been wanting to bring out and implement its own health policy coverage, which has not happened. And so the old scene remains. Public hospitals, some of them at better levels, some others not at very good level, provide free services, including medication. Many don't. So that divide, I think, Mahesh, remains, between public and private as it was.
So I'm looking at a scenario. I'm actually looking at a scenario in case you have a functional MHRB. There are services which are not there in the government, and the patient seeks this sort of treatment in private. By law, they're entitled to get this sort of reimbursement.
That is how it should happen. Yes. Yes. That's how it should happen.
So like sir said, PMJY is not allowed to be applicable in Delhi. Not allowed. You can't.
So in Dr. Vishal, I'm saying here, in case they don't have anything like that, you can get your bills reimbursed from MHRB. They have to issue an order for reimbursement from the government, or court will definitely say that it has to be reimbursed, because by MHCA's legislation, every person is allowed to have free access to treatment. And if they don't have access to treatment in public health establishment, they have to take it in private, and the government has to reimburse. This is the law.
Okay.
Can I briefly say that Dr. Mahesh Gowda is quite right on that last point. I guess it'll have to wait till some specific case happens in the High Court through a PIL. Like in many other instances, it will happen by case law. But I must briefly say, like some of our Delhi colleagues, Deepak Raja and Pankaj and Vishal and others will remember, up until last December, I had made sure about what Dr. Mahesh Gowda is saying, and specifically for Delhi. There was access to mental health care in public sector within 5 or max 10 kilometers. Now that I'm no longer there, we'll see how the government and IBAS and HMHA defend it. But Mahesh, to tell you frankly, from the time first bill of the current act came forth, I had been preparing myself, and I was ready as Director IBAS or Member Secretary, CEO, SMHA to defend. If somebody came up with a claim to say, I have no access, so please pay me for private. Okay, that was my role. And I was well prepared for it. Delhi has various agencies put together access to mental health care. What is interesting is, unlike what you said about, insurance agencies don't accept mental health rehab, most of you will remember 2O of mental health care actually defines mental health care as complete spectrum. If anyone of you looks up section 2 and subsection O, it's not just reaching at getting OPD service or inpatient once. Complete spectrum, including rehab. So if one applies that definition of mental health care with the right to mental health care, and Dr. Mahesh Gowda is saying, somewhere all over India and certainly in Delhi, the whole thing, tables will turn.
So actually,
I am waiting
just
for
looking
that
at,
to happen at some stage.
so it's not connected to mental health as such, sir, but including stroke rehabilitation, including rehabilitation for other people with terminal illness. The court has looked at this as no active treatment. Rehabilitation means there's no active treatment. So the moment we use rehabilitation, the court is taking a stance to reject claims. So if you don't use the word rehabilitation and say it's still acute phase management or extended period management or something like that, you may still be able to get away because there's no capping as right now.
Mahesh, yeah.
If I may say, sir,
I
because
see your point, but sorry, go on.
like the treatment of whole mentally ill people is a responsibility of the state per se. So taking that point, even rehabilitation should come under the gamut of insurance.
Can I say,
Yes,
Dr. Shashi, with all respect, while Mahesh and I seem to differ on it, and with all respect to you and all of us, see, what you or I or all of us believe doesn't matter. To counter what Mahesh is saying, and now being a mental health activist, much more than I was earlier, but even earlier I would have supported this from the position, very short, 2O. Mental health care includes analysis and diagnosis of a person's mental condition and treatment, as well as care and rehabilitation of such person for his mental illness or suspected mental illness. So Mahesh, my point is that what you are highlighting about what courts have excluded rehab from healthcare in general is in contravention of the 2O of Mental Health Care Act. So some High Court or Supreme Court at some stage in a given case will have to settle this.
Yes.
Because provision of 2O is in contravention of what you are saying correctly. Okay. So I would not like to couch it as acute treatment. I will go ahead and say as a doctor or as a user and say, boss, I want rehab. Law provides all facilities for rehab, Think about it, all of you, please.
Yes, definitely is needed, sir. If you look at PILs in this direction, we'll add a lot of clarity.
Will happen, yes, sir. Someday it will happen.
These are gray areas now, and court is interpreting legislations for us. So I hope they interpret it in a way that's suitable to a PWMI.
Yes.
Dr. Gowda wanted to say something. Dr.
Gowda? Sir, I'm saying the good thing is that at least we are getting some way ahead, and we are at least in acute illness, we are getting the change. Now, regarding the rehab, definitely there are very few facilities, and mostly the rehab is a burden of the family only. And the ones who are getting the facilities are the ones who are either too unwell or they can afford it at home. So considering that, I think the law provides that we should build more rehab facilities. And once we have more rehab facility, I think we will get the reimbursement also. But there are I've treated few embassy employees, US embassy employees, and they are covered under the insurance thing coverage, and they used to get the rehabilitation claim easily. So I would say that preventively we should not make those kind of a claim ourselves. And I have spoken in last 1 month with many insurance companies, and they are saying you chart out the rate for us. So I think this is a time where we can make the rate as per our comfort or as per our need, than going purely what they are saying. Because we are not liable to give the services at their rate unless until we start competing and cutting throat competition starts among ourselves, and the one says, okay, I will give in less, or the other say, I will give in less. So I think it's better to improve the quality of care at the moment and have more money in the insurance, buy the insurance into mental health care, develop more services and more rehabilitation. And this is the opportunity for that. Thank you.
Thank you. Dr. Manushi, you raised your hand.
Yes, thank you, Dr. Vishal. And thank you, Dr. Gowda, for informing us on this new topic of mental health insurance. My question is regarding the future outlook. We are looking with great enthusiasm about mental health coverage for insurance companies. But what are the pitfalls that we see? Because the US health system, as you know, is highly regulated and almost controlled by the insurance companies. And we need to devise a system that is somewhere in between the Western US system and maybe the NHS system. So where do you see the future going, sir? I don't see the mental health coverage by insurance companies to be a very a game changer for the large masses who actually avail of these services.
I think what you're saying comes with whatever you have faced in the last few decades of practice, sir. But we didn't have a strong legislation to support this sort of claims. But we have a very strong legislation. By right, the patient is going to fight. A lot of NGOs is going to come to the rescue. And what we can think of doing is, from the level of IAPP or IPS, we must develop our own minimum costing. For example, even a barbers association in a lot of cities and places have a minimum cost that they charge. Based on the place of practice, it could be rural, urban, metro. You could have a minimum consultation fee and say that it could be 500, 750, anything like that, and also add an additional thing based on a time spent with the client, based on the expertise and the subject issues that the client and the doctor is dealing with. This charge could be variable. So there must be a minimum consultation fees. For example, it's therapy. They can say it's 2,000 rupees for half an hour. So the consensus has to come up, and it has to be published in our society. It should be a part of our guideline to say that a doctor practicing, and if I'm registered doctor with IPS, it'll be my right to practice, and this was the minimum cost that I could entitle. So in the amendments also I proposed that they should come up with the minimum consultation fees for doctors. It looks difficult to imagine, but I don't want CGHS to fix a price and say follow this. CGHS has told that I must collect 150 rupees, and my Karnataka government says 150 rupees should be my consultation fees. This is on paper. So I cannot really survive with this sort of fee. It's totally unscientific and irrational. Unless we regulate ourselves and say that this is the minimum consultation fees, insurance people will get to divide and do a lot of stuff. So I think my other colleague also spoke about it. We must come to a consensus and have some sort of minimum consultation fees.
I think, yes, sir. As you pointed out, IPS and IPP should take the lead in this, sir. Yes, ma'am.
Adding to what Dr. Gowda has said, that like you said, that it should not be a big game changer. But I think if we have more of such programs, and if we conduct awareness programs for the patients per se, because I think more than 75% of the patients are not aware that any facilities exist. Once it is they are aware, then they will definitely try to take help, and things would improve.
Actually, looking at other thing, ma'am, if you call the key insurance providers in private, call somebody who's a representative from IRDA, have this sort of meetings, I think a lot of things can unfold and transfer into actual reality, ma'am, because it is a need. There's a legislation. They are willing to support. The insurance company is also tell us what we should do. Should we cap number of days? Should we give a predetermined packages to illnesses with exaggeration and things? They're asking us for direction. They themselves don't know. We don't have data to tell them either. So I think if we evolve and come to some sort of consensus, I think we may reach a stage when a patient is going to definitely get reimbursement, and I think we stand to gain. For example, my consultation fee is going to be 500. When I claim insurance, generally by all other specialists also increase the cost when they send it for reimbursement. There can be some standard deduction. So if my bill for inpatient hospitalization could be 25,000-30,000, generally insurance company can get billed for 50,000, and a part of it will be a standard deduction. You still stand to gain, is what I think, ma'am. We must work together with insurance providers, is what I think.
And definitely we should work for the OPD patients also, because that is a mainstay. Majority of the patients are OPD, and it's because the long-term treatment is required. So that should be included in the gambit, because only then patients will really benefit for maintaining.
So Dr. Nimesh sir raised their hand, and Dr. Rajiv, and then Gaurav sir after you in the.
Right. Thanks. Can you hear me? Yeah. A couple of things. One, see what we are discussing about whether it will become a game changer or not. To me, it seems that depends on how the overall direction of health insurance goes in this country. I don't know, Mahesh, if you have any updated figure, but my last information was that even about health insurance, it's about 10% of the Indian population that avails of personally paid health insurance. Large part of the population still depends on either government sector or out-of-pocket expenses to private practitioners. So the trend of going towards health insurance in the general population, once that increases, hopefully it will follow suit for mental health. I think it's going to be a little while. But I agree with Manushri's caution. Let me give you quickly 2 examples from what I have seen in the US, actually. And insurance companies will control us, let's face it. Mahesh, your idea of we working with insurance companies is, like many other things, very good in theory. They are sharks, boss. Over time, insurance companies and HMOs are money-making sharks. 2 things that I've actually witnessed very painfully many times in the US. If the insurance company says admission for so-and-so condition will be 7 days, 8th day morning, you or I as a doctor have to discharge the fellow, whatever be our clinical opinion. It's terrible, heart-wrenching.
Sir, I'm actually
know
thinking like if the insurance pays for 7 days, the rest can be paid by patient in case the package is not suitable. Sir, it is something is better than nothing. And the
I
package
know,
is what?
Correct. I agree. The point right now is between doctors and insurance companies, because once the insurance sets in, the out-of-pocket expense rates will go up so much that very few people can afford it. Much worse is the example of misuse, like you also mentioned very well. See, at Hopkins, I've actually seen this happen. A drug abuse or alcohol person, when he runs out of money and drugs, come to the Hopkins emergency with a smile and says, "Doc, I'm feeling suicidal."
Yeah,
Okay,
this
the
is a very,
doctor
very
has to
catchy
admit
word.
him. He has to admit him. The fellow gets a clean bed and nice food for 1 week and goes home. So that's the other part of the misuse. But this rehab part that you were discussing hopefully will happen, and the full spectrum. Outpatient, really, Dr. Shashi, is going to be a long while. Outpatient and therapy sessions. I don't know how Mahesh feels, but outpatient to be included. Lastly, IPS and IPP always keep saying came together only once, Mahesh, and most of you were not around then. Way back in 2001, when after Erwadi tragedy, Supreme Court took up that suo motu notice and Achal Bhagat joined, Sarthak said, one time that we had a joint IPS IPP task force. Rajesh Nagpal, Sunil Mittal, and I wish we do that together, because I'm totally with you. IPS IPP will have to come together to advocate with government and insurance agencies. Otherwise we will be actually at the losing end.
I think we also developed ideas together, sir, if I'm right.
Yes, sir. Many officers were from that time. Yeah, Sunil Mittal, Rajesh, and I had such, and we tried. Can I also say to what somebody was saying? If I understood correctly, yes, we doctors becoming litigants or petitioners will never work very well. It will have to be through users and carers. So, like we have been trying to do in Delhi from IBAS and DPS and some other centers do, Bangalore is active. We will have to, most important, Mahesh, it seems to me, we'll have to collaborate with users and carers.
Correct.
Because this is where our interest is common.
Correct.
Users, carers, and providers. So if we come together and then fight this system, thanks.
Yeah, Dr. Rajiv. Dr. Rajiv is in Gangaram.
Yeah.
Dr. Gowda.
It was a very nice presentation, and the discussion going on is very helpful, very informative. So I had few patients admitted under me who wished to had Mediclaim. The practical difficulty is that the insurance company wish to deny the claim, and they will ask the same question repeatedly again and again through the mail. And it becomes very difficult to answer the same question. Why was he admitted? How much violent was he? Was any injection given? If injection was not needed, why was he admitted? What is the need to admit the suicidal patient? Can't he be observed at home? So these kind of questions repeatedly become very frustrating. When you are busy in your clinic and you have to answer all those questions time and again in written form, they will just turn around the language and ask the same questions repeatedly.
Sir, I think I have a solution for this. My other colleague also mentioned there are intermediaries who are going to charge you 10% or 15% to manage all your paperwork. On the other hand, if you look at most corporates, what they have is they have their own personnel who are designated staff to manage the insurance-related paperwork. So we have to evolve a certain set of fixed, descriptions of symptoms, fixed criteria for including this patient for admission. So we have to talk the insurance language to them. So there are medical teams in the insurance company which are paid for rejecting the claims. If they're able to find one sort of discord in what we are writing, and if they're able to reject a claim, it's a big plus point for the insurance company, and they get paid for those sort of work. So 90% the mindset is they want to reject these claims. So I understand from where they come. So we have
won't it be better to have a
insurance.
psychiatrist on their side also?
They'll have medical doctors in general, MBBS trained doctors who look at claim
But
information. So
see,
we have to
to have
develop insurance language.
Courtesy
such
and
kind of a
Vishal, can
person
I
when
butt
you
in?
have a
Sorry,
sir,
I have
to ha-
something very interesting there. Sorry. See, for our young friends, not only next generation, but the generation after that, if I may give you a career idea and set kitten amongst the pigeons, my contemporary classmates from Gujarat, within the 5-10 years of their immigration to US, some of them were smart enough to join as consultants or advisors to the insurance companies and HMOs.
yes,
Rather than as a clinician being controlled by the company, you become the advisor in an HMO or company and then control the doctors.
But then
right,
control the
sir.
doctors positively, because
Right,
on
sir.
the
That
other
never
side,
happens, ma'am.
That never happens. That never happens.
There's
So-
also a level of redressal in the whole system. If the medical team rejects, there's an ombudsman in each insurance company that has to look at this sort of claims. If he also denies, then it has to go to court. So before going to court or trying to have any other complaints of grievances, the ombudsman is the first level of contact to address grievances.
So,
See, what has been good in India, I think, in mental health, and which will also help us in insurance sector, is the active involvement of the judiciary. Unlike most other countries, and US is too divided, state-wise. India, quasi-federal, fortunately, high courts become applicable across states and Supreme Court, of course. So the hope, like Dr. Mahesh Gowda is saying, will be ultimately the judiciary,
Dr. Ashwini raised hand, but before that, Dr. Gaurav Gupta wanted to make a point. Gaurav, sir, you want to make a point before I go to Dr. Ashwini, or should I go to Dr. Ashwini? You're mute, sir. You're on mute, sir.
So the first point is that, of course, it's a new thing for the insurance to start processing mental health, mentally sick applications. And I think they are also going through a lot of troubles. And that there is an opportunity for us to guide them in a right way, which is going to be beneficial for our patient, than feeling frustrated. So Rajiv, your feeling frustrated is actually not right. Rather, you should see how frustrated insurance companies are there. They don't know how to process the claim. And there
Right,
is an
sir.
opportunity for you.
Right, sir. Definitely.
So I think we should take the advantage of the opportunity. The important thing is we cannot and we should not give up at the moment. We have all the opportunities to move the insurance company in our favor, because ultimately they will hire few psychiatrists, and the hired psychiatrist will tell them the trick of the trade and how to abuse us. So for time being, for a couple of years, till the psychiatrist reaches there and manipulates us, we can have the gala. Now, the second thing is that I don't agree with Dr. Gowda about the disability and the choice of the. See, a alcoholic drinking excessively and not controlling, and ultimately out of a distress going there or out of manipulation going there. That is none of our business. See, as a doctor, we have a right to help somebody, and somebody is coming with the and lot of patients who come out of those situations get better, and we have to help them. Now, similarly, a suicidal person can be out of severe stress, and we have to help them. So I think feeling that this is a choice of disability, no, that's not true. And any patient who is coming in a crisis is a right for him to get the help. So we should never think that that patient is kind of a taking advantage of insurance company. Now, third thing is that insurance or no insurance, we have a right and the patient has a right to take the services. Now, the government sector is not affected, but the private sector need to take over. And many medical disorders are also not being claimed. The OPD services in means for the blood pressure or for the diabetes are not claimed by the insurance. So that's all right. At least we are getting some advantage or some progress in the situation, and we should be happy about the things what is happening. Thank you.
Just to add before I go to Akash, also if we start asking for claim for OPD consultations, most of our time will be spent on paperwork and not able to see patients. We'll have to put in staff to get that thing done. We have to, we'll have maybe 2 or 3 staff, like how these hospitals who have CGHS panels, they have huge staff to manage all that paperwork, which is tremendous, And
Vishal, I think it's still financially viable, if you ask me. There
for
should
the-
be an
OPD.
option.
For the
There should be
OPD.
no, yes, whatever you do, there should be a system to take care of it. I don't want you to spend your time, but the system should take care of it.
Okay. That's why we need to learn always from you, Mahesh. Always. Okay, Dr. Ashwini, over to you.
Okay. See, recently I had a lot of interaction with the groups practicing neurology, psychiatry in US, and I was informed that a number of insurance policy insurance agencies there, and now over the last 2 decades they have learned the trick, and they come and negotiate with the psychiatrist and the neurologist very heavily. So it's for the insurance companies in India, it will be shorter window before they come and reach out to the psychiatrist and strike a very hard bargain with the psychiatrist about the fee. So as Dr. Gaurav mentioned, the time window when you can have your own say is not so long, but it is going to be very short. This is my comment.
Thank you, sir. So if you can just give an example of how heavy they are. Like, can I give a figure? Let's say it's 100 rupees a consultation fees, how heavy they are negotiating with the doctor. Yes, sir, we'll come to you, Dr. Gaurav. Yeah.
So what they have done is that, see, they also pick up that who are the practitioners who are busy, and because they're also the consumer wants that, okay, do you have this doctor on the panel? Do you have this doctor on the panel? Right. And then accordingly, they pick up the practitioner on the panel. So ultimately, it is going to be the same thing here also. See, the practitioners who have a larger practice, they will be able to claim a higher fee from the insurance. The practitioners who are not in that position, they will be able to claim a lesser fee from the insurance.
Okay. That's I understood, sir. Whoever has more bargaining power gets more money. That's
right.
Yeah. Similar to what has happened also with these teleconsultation platforms who manipulate youngsters to go for their smaller fees, and they come begging you, asking for, please come to the platform. That's
Yeah. Right. Exactly.
Yes. Dr. Gaurav, your point. And before we go to closing comments.
I think the standard thing is that CGHS rate. So very soon, if you want to see insurance OPD patient, you will get only CGHS money. So it's not going to be easy. And there is a standard, or they will say that whatever PMJ scheme is there, you take that rate. So if you are ready to negotiate, I think we all should say we are not going to see them. Like for CGHS, I don't think so. Any private psychiatrist in clinic see the CGHS patient as on panel. So if you don't see, similarly, you have to have a strict refusal that I will see no insurance patient and I will only see the paid patient. If you have that refusal, then let your patient claim from the insurance company. You have no headache of the paperwork. You have no headache of any cutting in the money, and you will get your complete money. Let the patient and your insurance company decide. And that is going to be the win-win situation where you tell insurance company, if you want your patient to come to us, you give me ₹1,00,000 deposit. I will keep sending you the bill that these are the patient visited me and only a copy of prescription. Let other paperwork be done by you. It's your choice whether you want to take me on panel or not. I don't want to be on your panel. So I think currently we are in that winning situation. But tomorrow, as there are going to be few doctors come to their way of working, we will start working like them. And if we want to see CGHS patient, it's going to be the same.
Right. Okay. Thank you. So if there are no more questions,
Can I, Vishal?
Yes, sir. Yes, sir. And then we'll do the closing. Yes, sir. Please.
Vishal?
Yes, sir.
Last
Please,
thing.
sir. Yes, sir.
One delicate point, and then come to my major thought. The delicate point is that I think there is this big 80-20 myth. 80% of healthcare utilization happens in private sector, 20% happens in government sector. That was for diarrhea, fever, cough, primary care. For all specialties, tertiary care, including mental health, and our own data will say public sector still looks after 2/3 to 3/4 of the service load. Private sector does 1/4 to 1/3. That's one part delicate. The 80-20 myth is a huge myth. But to major point, because of that, I think in addition to what all we are discussing about private sector service provision and liaising with user carers and insurance companies, what we as IPS and IAPP also need to do is really do great liaison with government for the public funded healthcare. Like Mahesh mentioned, the Ayushman Bharat is the largest health insurance scheme in the world and will ever be. So my thought is that both IPS, IAPP, while working for the private sector, and I'm now in the switch phase from one sector to the other. Okay, please realize I'm in the switching phase. Okay, so having seen SMHA also, I can tell you, really we need to work much more, Mahesh and Vishal and everybody, if you agree, with the government for getting the mental health components, all aspects in the Ayushman Bharat. And that still remains weak. To my knowledge, last point, to my last awareness, the CGHS had already made a rule that the CGHS reimbursement will be only for those hospitals which have NABH accreditation. So if we want private sector to be paid by public funded insurance of the government, please start preparing for accreditation of your inpatient settings. Because at some stage, the government is going to say, okay, we will reimburse the private mental health care bills, from public funds, but only if you are quality assured. So one push for NABH, really, whoever might be interested in the long run, it seems to me, that's the direction.
Thank you very much, sir. These are very important lessons and comments for the future of mental health insurance in India. So, Dr. Mahesh, any comments you want to make before we close the session, and then hand it over to the chairpersons for their closing comments?
I think the current area is a very difficult area for the patients, for the insurance providers, and for practitioners like us. But I think I see a future in the next 2 to 5 years. A lot of things will be ironed out, and we'll have a lot more clarity. I'm sure insurance is going to be there, and majority of the patients may have claims. So we have to gear towards evolving our services and systems, like the staffing, making sure our paperwork is good enough, and make sure we develop the insurance language to actually get our claims done. I think it's definitely possible. We can have workshops on effective documentation for insurance purpose, look at do's and don'ts, look at actual forms of insurance companies, and see how best we can have some sort of scrutiny committee set up within ourselves to reject. It can be a good workshop to evolve a system where we can get reimbursement done. I think the future is good is what I'm thinking. The road right now looks less traveled. and difficult, but it's only the short time. I think the vision is like, next 2 to 5 years, a lot of things will be better.
Mahesh, positive as usual, Mahesh. Thank you.
Dr. Vishal, just
Yeah.
let me come in here.
Yeah, why not? Why not? Boss, you are the boss. How?
Before we close the session, I just a lot of comments and wishes are coming for Dr. Mahesh for excellent presentation. That's on record. And just before close, I would like to take up comment from Dr. Manjeet Bhatia, sir. Bhatia sir has written excellent presentation. Let us compile a draft and write to Finance Minister and IRDA mentioning what is done in UK, USA, etc., and what is obligatory in MHCA. That is Bhatia sir's comment, and I just want to put on record. There's a lot of wishes from all of the participants. Thank you very much. Now, Dr. Vishal, back to you.
So, over to Dr. Shashi and Dr. Gaurav for their closing comments.
Thank you, Dr. Vishal. It has been a really wonderful presentation by Dr. Mahesh, and all of us have been entire. But it's definitely, I also feel it's a positive step. And as the road is less traveled, so we'll have it a bit easier to make footprints where it is less traveled. So if all of us really work together, I'm sure the patients it will be the benefit of the patients. So it's a good topic, and IPS and IAPP should try to collaborate and bring out a draft, which would, show the insurer companies also, because as everyone is saying, that even they are not aware of the exact situation. It's new for them also. So till they are at an impressionable stage, let's make our impressions. That's why I speak on this.
Thank you so much, ma'am. Thank you so much for those wise comments. Dr.
Vishal, this PPT can be shared. I've sent it to both of you. You can put in the group. There was a request for PPT.
Yeah, I'll do that, man. Thank you. So I was going to ask that. So thank you for already.
Thank you, sir. Thank you. We will do that.
And Dr. Gaurav, your closing comments.
I would thank DPS and thank you, Vishal, to encouraging me to be part of this, because normally I'm a shy person. And I think definitely there is a huge opportunity, and there are going to be big investments in mental health. As we are seeing, a lot of news are there. So I think it's an opportunity we should consolidate and make the mental health system and private sector bigger and bigger, so we can deliver better services in future. Thank you.
Thank you, sir.
Like you can see behind Dr. Gaurav in his background.
Dr. Gaurav Center in the background.
Yeah, huge and a very beautiful one, I would say.
Yes. So Gaurav is a role model for all of us in many ways. Thank you. Dr. Deepak Gupta is also here. He hasn't spoken ever. Do you want to speak, sir? Any from your perspective of a...
No, ma'am. See, I work with children and adolescents, so I don't know where this all will, but yes, definitely I totally see that we together work as a team and come out something which is very consolidated, because I've been seeing this almost 25 years that, people are working in bits and pieces, but, we should come out with a document which supports each other and help us, everyone, to grow together. Everyone is working in their own bits and pieces. I'm working in my own, Dr. Gaurav is working, Dr. Mahesh is working, everyone. But I think we should come out, and as mental health is absolutely on the demand and things are growing up, we don't want anybody should steal away the show. Nobody should steal away the show. It should remain with psychiatrists. It should not go to anybody's platter. So, and in the end, we should be the flag bearers and we should take it forward. So high time we should take it action and come out before somebody else does it, because somebody will do it. Somebody will do it. So ye to mat socho koi nahi karega. We have to do it. हम नहीं करेंगे तो कोई और करेगा, because and the next this whole decade is a mental health whatever you can say, so we need to be very careful and be fast. We should act fast rather than be on a tortoise or a turtle speed. That's what I want to say, and I'm always there in my capacity, though I work with children and adolescents, but I'm always there with DPS.
Thank you, Dr. Deepak, for inspiring comments. And that's very true, very timely. We need to work together, and that's the whole point of having these sessions, to have some kind of a dialogue where people can cooperate, coordinate, and understand each other's thoughts. Like we all had different thoughts. I have a different thought. Dr. Gaurav had a different point. Dr. Ashwini brought a different point. Dr. Mahesh brought a lot of points from his experience. So that's very nice. And Dr. Ajiva shared his experience, his frustration, which Dr. Gaurav said, you should be happy. So there's so much of good takeaways from today's meeting. Dr. Anita ma'am is also listening very patiently since morning. If she wants to say a few words, ma'am. You need to unmute, ma'am, before you speak. You need to unmute.
Yes. See, what I feel is that the ball is in our court now, and we have to collaborate with others. Like, we did with the Mental Health Act. We have to collaborate with the carers, with the other mental health, stakeholders in this whole, area. And one thing which I am very hopeful about is that whatever we plan and ultimate document which is ready, that will be probably taken up very positively by the judiciary at the moment, because we have a very rights based chief justice at the moment. So if we all of us together, psychiatrists, psychologists, social workers, NGOs, patients, carers, and insurers included, if we reach a consensus, we are going to gain a lot, and we can make a good what should say, as Shashi Rai was saying, that we can make a good impression where it's needed.
Thank you, ma'am. Thank you. Thank you, ma'am. So my thoughts,
Deepak Raja is here, yeah.
Yeah,
Deepak is here.
I was going to, yes, he's there, but I think he's traveling, so I didn't bother him. I don't know if he can speak a few words.
Oh, okay, right. Okay.
Deepak, can you speak? Deepak is just unmuted him. Deepak? Dr. Deepak Raheja? He's unmuted, but I can't.
Okay.
I think I saw Bora ma'am also come in, but I didn't, because you mentioned they were traveling, so I didn't. So the interaction we're having today, it reminds me of the interaction we're having when the Healthcare Act came in. A lot of people were very scared. What will happen to our inpatient settings? What will happen? We may lose everything. We may lose rights. People were very scared of advanced directives. After we will not be able to treat the patients at all. What is an NR? All those issues came. But I think we Indians have a very unique way of doing things, and we have such flexibility of around things, that I'm always hopeful that no matter what happens, we will not go UK way or US way. We will develop our own Indian way of doing things. We always done that. No problem, Dr. Deepak. Thank you. We knew you were in flight with, I think, with ma'am also. So thank you for joining. So I think it's very important for us to, we should have this discussion. We should make a draft documents. We should submit our understandings to the ministry and to the IRDA. But I think we will find a way around doing things in a better and good way. And that's how our civilization survived for thousands of years. So that's my closing comment. Over to Dr. Manushree for the vote of thanks and closing the whole thing.
I said, I read a message, Dr. Manushree left.
Okay, left. Oh, he was there. I think, so we have backup, Pankaj.
Ashwini, Joint Secretary.
Thank you, Dr. Vishal. And I would like to thank our speaker, first of all, Dr. Mahesh Gowda, so presenting it so nicely and putting it so everyone, layman like me, in insurance area can understand. Because till now, what I used to do, patients used to come to my indoor setup and ask regarding insurance. I just used to tell them clearly in one line, I don't have insurance, my hospital is not unpaneled, directly talk to your insurance agent guys. So I don't want to get into all this mess and all this hiccups. But after listening to you, Dr. Gowda, a person like me is also thinking to work on these lines. That's real thank you for this lucid and enlightening presentation, I would say. And also like to thank you, our chairpersons, Dr. Shashi and Dr. Gaurav, taking out time from their busy schedules and making this successful. And I would miss my duties. I would thank our senior psychiatrists like Desai sir, Ashwani sir, Deepak Gupta sir, Reja sir, ma'am, and everyone on this panel making a success of our first baby child edition. And I would like to thank everyone, including our president, Dr. Vishal, Dr. Manu, and for making this whole episode a success and interactive. Thank you very much. It was very enlightening. Have a great Sunday. Enjoy yourself. Hope to see you soon. Bye-bye.
Thank you. And because I got a message saying, please share the recording. I have recorded this session, so I'll be uploading it on YouTube, but I will not make it public. I'll leave a link with the group, so anybody who wants to watch can watch. This is still ongoing discussion, so I don't want to make it a public to all the thing. And for the similar in the future also, when we will plan to do this once a month, hopefully, and I'll keep recording them. I'll keep uploading them on the YouTube's with the link for the private viewing for all of you. Okay. Thank you all for joining in, and see you next session. Thank you.
Bye bye.
Thank
Bye
you.
bye.
everybody.
Bye bye
Thanks.
everyone.
Thanks
Bye.
for
Good afternoon.